Recording, okay? Okay, so first thing first, in emergency medicine, the patient can come with trauma, a patient can come with pain, a patient can come in many ways. So it's how you are going to start approaching. So first thing, you are going to start with the assessment. So in the emergency, it's kind of different. In OPD or in family practice or in a clinic, it's kind of different. They don't say OPD, they say clinic here. So in clinic, it's kind of different. If a patient comes in clinic, we start with taking history. Here, the patient comes in emergency. If patient is conscious, then you can start with history, but not. And let's suppose a patient comes with trauma. So we are going to start with rapid primary assessment. Okay. And that's what they are looking for, the exact same words. Okay. Even when you're giving NACOSKI or even you are giving QE1, they are looking for the same answers, especially in MCQs. They try to give you air maintenance. They try to give you a second option with air maintenance with C-spine. They try to give an option with air patency. So, the words are kind of same, but they are looking for what are you going to see. So it's best to go for the words accurately, okay? So we are going to start with a patient assessment. So how the patient came in trauma, how are we going to start? So rapid primary survey, we're going to start with airway maintenance with C-spine control. So a patient who just got hit by let's suppose motor vehicle or something like motor vehicle collision had happened or something like that, right? So he had just an accident or hit by a bus, anything. So first thing is checking the air maintenance with C-spine. Don't forget about C-spine. Okay, there is questions. We are directly asking what are the first thing that you are going to do. So the first thing is putting a collar, C-spine collar. So they want you to write down that what are you going to check is basically C-spine control and then air maintenance. Then comes the breathing and ventilation, then circulation and disability. Okay, even in interview, I mean, yeah, that's kind of little bit too ahead, but yeah, sometimes they like to ask these questions too. How will you approach the patient and stuff like that? Okay. So it's very useful how you are going to start from your basis. So you make your basis very good so you don't have any problems ahead. Okay. So disability, we're going to check for neurology and then coming from exposure environment, that comes separately. So A, B, C. A includes airway maintenance along with C-spine. But it does not mean that every accident you have to do the C-spine. If they already mentioned in the question that the C-spine or head is okay, there isn't anything like that, or there is only injury on the hand, then in that case, we can skip about C-spine. But in case of trauma, which is basically a motor vehicle collision or something like that, usually we kept the C-spine control to make sure that we did not miss out anything. Okay. But let's suppose if a patient comes with poisoning, so we don't go for C-spine. Okay. So airway, breathing, ventilation, circulation, disability, and exposure and environment. Okay. Then is continually reassessed during secondary survey, changes in hemodynamics. So you have to highlight this whole part. Okay. Then changes in hemodynamic or neurological status. Necessities are returned to the primary survey beginning with the airway maintenance. So if let's suppose anything is there, you can go back to the primary survey. Important, always watch for the signs of shock while doing the primary survey. So it's very important. You have to check for the like vitals. Okay. Addressing the ABCs is the hallmark of the emergency department. Wherever they say a patient present with emergency, they are looking for ABC. They are not looking for how you're going to call the specialist. They are not looking for anything else. First thing is, are you going to save the patient or not? Okay. In the setting of cardiac arrest, the approach is basically starting from circulation. Okay. Circulation, airway, breathing, or basically doing the chest compression. Chest compression does not mean like circulation is basically, I'm talking about vitals. Okay. So chest compression is basically, let's suppose is a cardiac arrest, like a patient is not having systole or asystole. In those cases, we are going to see if this patient needs chest compression or not. So we are going to start with vitals, then going to the chest compression, then airway and breathing, and checking his breathing as well. So CAB is also applied in massive trauma situations in the setting of massive blood control to treat hypovolemic shock. That's why they said in every primary survey, you have to check for the hypovolemic shock. Keep checking the vitals. Approach to the critically ill patient. So checking vitals is basically, we will start with checking vitals every 5 to 10 minutes, then we can increase the time duration as the patient start getting stable. Approach to the critically ill patient, rapid primary survey, resuscitation, detailed secondary survey, and definitive care. Signs of obstruction, they usually ask this kind of questions in the MCQs. or in NACOSK as well. Signs of airway obstruction. How will you find out that the patient is having airway obstruction? So starting with agitation, confusion, universal choking sign, respiratory distress, failure to speak, dysphonia, stridor, cyanosis. Okay. So we do know cyanosis, but we usually miss out rest of the stuff. So that's why the agitation, confusion is also the signs of airway obstruction. Coming to airway, primary priority is to secure airway. You can just read this one. Assume a cervical injury in every trauma patient and immobilize with the collar. Assess ability to breathe and speak. So when you are reading this emergency medicine, I would like you to imagine yourself standing in emergency medicine, like our emergency department, and how you, receive a patient. So that's how it works. Assume a cervical injury in every trauma patient and immobilize with the collar. Then assess ability to breathe and speak. Listen for the evidence of airway obstruction, like stridors. Can change a rapid through, therefore, reassess the frequency, assess for the like facial fractures, edema, and burns. Okay, so then coming to the airway management, how you're going to the airway. Let's suppose we did airway checking and then now we find out there is something wrong. Then what are we going to do? So we are going to check for the airway management, checking for vitals. Vitals is basically checking for oxygenation and ventilation. Then airway basic airway management is protect the C-spine. As I said, C-spine is very, very important. A lot of people do miss this one, especially including me. So that's why I'm keep on putting a lot of pressure on this one. Then chin lift or jaw thrust to open the airway, sweep and suction to clear mouth of the foreign body. Then temporizing the measures, so like nasopharyngeal airways or oropharyngeal, depending on the which one is present, the gag reflex. So this is a very common question. Even they ask us when we are doing the practice, they're like, how you're going to check that this patient needs a nasopharyngeal airway or oropharyngeal. So depending on the gag reflex, if the gag reflex is present, this patient is conscious, so you can go for naso. If the gag reflex is absent, you can go for unconscious. This patient is basically unconscious, so go for oro. Then rescue airway devices like laryngeal mask airway, combi tube. Then especially for the children less than 8 years, we go for transtracheal check ventilation through the cricothyroid membrane, rarely used because it's mainly the pediatricians who usually deal with this kind of things for the children's. Then definitive airway management, ETT tube within line stabilization for the C-spine, if applicable, then orotracheal plus rapid then preferred. Sorry. Okay, so then the nasotracheal may be better tolerated in the conscious patients. So surgical airway, if unable to intubate using the oral or nasal route and unable to ventilate, then cricothyroidectomy. It's very end thing and it's only done by surgeon. So usually at that point we call the surgeon. Then medications that can be delivered via ETTs. Basically, these are the questions they like to ask in MCQs as well. So naloxone, atropine, Ventolin, epinephrine, and lidocaine. So Ventolin is important. I just got recently a patient where we have to give this. So contraindication to intubation, so supraglottic and glottic pathology. So just one thing here highlighting, because I think when we are reading a lot of things, we think that, oh, this is not important. But in Canada, especially in this emergency in Canada, we usually try to apply the bookish knowledge. So I would suggest when you are reading this one, go for the bookish knowledge, okay? Especially when you're attempting an exam. Supraglottic pathology that would preclude the successful intubation, then provide safety. For example, SARS-CoV-19 precludes the intubation, CPR, and the arousal generating procedures in the absence of the full PPE. Then trauma requiring intubation, no immediate need or immediate need. How are you going to check for that one? So C-spine injury, positive, then we are going to do fiber optic ETT or the nasal ETT. If negative, then oral ETT. If both are unable, then rescue devices or the cricothyroidectomy. If it's an immediate need, patient is having apnea or breathing problem, apnea, go for oral ETT, unable, then go for the same rescue devices. If breathing, yes, then oral. If breathing, no, then go for nasal or oral, depending on the problem. So breathing yes means the patient is having a breathing problem, then go for oral. If breathing no means the patient is not having breathing problem, then you can use the nasal as well. Unable, the rescue devices or the cricothyroidectomy. There are rescue techniques in intubation, the bogey and then gyroscope, lighted stylite, and then fiber optic intubation. I'm going little fast. If someone wants me to slow down, just let me know, okay? Then video laryngopharynx, it's just the names. You can read this one, stylites, Bonfil, rigid, and Sensa scope, okay? Then guide channels are air tracks, Pentax, rescue, and then traditional and gyroscope. Then coming to the breathing assessment, how are you going to breathing assessment? So quantitative measurement of the breathing functions, like checking for the rate, oximetry, ABGs, and arterial gradient. So basically, ABGs is very, very important. I would suggest like usually would do this, okay? So don't just miss out this one. So rate, oximetry, because the vital monitor is already attached with it, so we can check it from there, and then it would send ABGs right away. Then look mental status, like how you are going to check anxiety, agitation, decreased level of consciousness, check movement, bilateral and asymmetrical, then respiratory rate, effort, nasal flaring, and increased work of breathing. So here they can ask you, how are you going to assess the patient? So before feeling or touching the patient, you have to assess the patient by looking. So in the looking, what are you going to look? Okay, so in MCQs, they can ask you, if a patient brings in trauma, how are you going to see this patient, or how are you going to assess this patient? Just by looking, okay? So then comes to the listen, auscultate for the signs of obstruction like striders, breath sound, symmetry of the air entry, and then air escaping. So that's how we're going to start with auscultation. Now, starting from the feel, okay? So starting from how you're going to look, by looking, you can already tell that this patient is having a good breathing assessment or not. So especially when you're practicing, they do like to check if you have an idea of to triage the patients, okay? So tracheal shift, chest walls for crepitus, like subcutaneous emphysema or rib fractures, flail segmentation, sucking chest wounds. Now, when a patient comes to an emergency, what kind of ethical scenarios that they can touch, right? So in that cases, they usually like to ask like, yeah, so in a rib fracture case, if I don't forget, I just want to mention it here. So rib fracture case, there was a case patient who was keep on asking like, I want to do a surgery for rib fracture. And we don't do any surgery for that. There is only painkillers that we give for the rib fracture, right? So it was a very like a complicated case where we have to counsel the patient about this one. Although it was an emergency case scenario, but it was supposed to be dealt by a family medicine thing. So after giving him painkillers for the rest of the follow-up, we referred the patient back to his family medicine or family physician, right? So it was all about counseling. So in this case, the patient was having a problem with rib fracture. So they can ask you, so you don't have to think about, okay, this patient is having rib fracture. They already gave you a diagnosis. Now they want you to see how you're going to approach this patient. So listening, apologizing, counseling, telling them what it is about, how they're going to deal it, and stuff like that, instead of just checking the airway breathing circulation. Okay. Then treating of the breathing, treat likely underlying causes like bronchodilators, epinephrine, diuresis, depending on how the breathing problem is presented. So epinephrine is basically in the case of allergies, okay? Or having an asthma attack, not asthma attack, like a sort of allergy attack. Then optimize the oxygenation, the nasal prongs, then move to the simple face mask, then ventral mask, non-rebreathable mask, and not high flow. Like that's how you slowly switch on to from one thing to another. Then bag valve and then CPAP to supplement inadequate ventilation. Noisy breathing is obstructive breathing, unlike until proven otherwise. There is a lot of until proven otherwise in Toronto notes, and I want you to highlight all of them and read all of them. Okay, they do like to check this one. Then coming to the circulation, inadequate organ and the tissue perfusion with the blood, oxygenated blood, like which one are those organs? The brain, kidney, and extremities. Major types of shock, very, very important. Shocks are very, very important, okay? Hypovolemic, cardiogenic, distributive, obstructive. What are the causes? How it's the first line management of those ones? What is the investigation? So especially for the shocks, you need to know these three things. Then nasal prongs, so you can see how much oxygen they got delivered from nasal prongs, face mask, and these ones. Then clinical evaluation, early and late. Early starting with tachypnea, tachycardia. So everything is high, 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 and then slowly start getting low. It means now it's getting late. So tachypnea, tachycardia, narrow pulse pressure, reduced capillary refill, cool extremities, and reduced central venous pressure. So then come to the late one. Late is basically hypotension, altered mental status, reduced urine output. Shock is a trauma patient in a hemorrhagic until proven otherwise. Okay. So I told you this until proven otherwise are very, very important. And in the MCQs, they do like to check by putting a statement and they want you to do it right away. Okay. So, sorry, did they say if someone Okay, so then estimation of the degree of the hemorrhagic shock. So there are 4 type of shocks, like classes of the shock. Okay, how much the degree of the loss? How are you going to check without with making an assessment from their blood pressure and respiratory rate? It's very unlikely they do ask you for the blood loss, like how much cc it is, like, but you never know who's making the paper, like who's conducting the question, so you never know. But they do like to assess that you know the degree of or the class of the hemorrhagic shock. Okay, so the percentage of the blood volume is less than 15%, then in that case the pulse is little high, like less than 100, then blood pressure is normal, respiratory rate is 20, capillary refill is normal, urine output is okay, fluid replacement is crystalloid. Now coming to this one, in the second one, it says that the 750 to 1500, then percentage of the blood volume is 15 to 30%, pulse is more than 100, then blood pressure is still normal. Then respiratory rate is 30, like getting a little bit higher, capillary refill is decreased, urine output is 20 cc, then your fluid replacement that we are going to do is crystalloid. Third one is 1500 to 2000. In that case, the blood pressure is also decreased, and but the pulse is high, the respiratory rate is high, capillary refill is decreased. It means the extremities will be cold. Then urine output, as the urine output is one of the most important things, so don't forget about this one, the Foley's catheter. Okay. Then we are going to, in the third degree, we start with the crystalloid plus blood. A lot of people go with the blood, but crystalloid do got a lot of help in the third one too. So we can wait, but it's better to keep blood in your hand. Then in the fourth one, same. The blood pressure is going to be decreased, respiratory rate is going to be high, pulse is high, percentage of the blood volume is more than 40%. Then urine output is like there is no urine output at all. Then fluid replacement, blood and crystalloid both. Management of the hemorrhagic shock, very, very important. And they do like to ask this one because it comes with a motor vehicle collision or any kind of stab wound or any kind of like injury. Then they're going to start with clear airway and assessment breathing, either first and simultaneously. Apply the direct pressure on external wounds while elevating the extremities if there is any injury on the wound. Do not remove the implanted objects in the emergency room setting, as they may tamponade the bleeding. Then start 2 large bore IV line in the brachial and the cephalic one of each arm, depending on if the veins are visible, how does it work. Then permissive, the hypotension with the packed RBCs transfusion, ideally cross-match. If cross-match blood is unavailable, then we go for O negative for women of childbearing and O positive for men. Use fresh frozen plasma, platelets, or tranexamic acid in early bleeding, not in the late bleeding. If available, activate the massive transfusion protocol. Then consider the common sites of the internal bleeding. Which one are those ones? Basically abdomen, chest, pelvis, long bones, and GI. This is also important. They can ask in the MCQs. Where surgical intervention may be needed, in which cases you are going to call the surgical department, okay? Common sites of the bleeding is basically external, chest, abdomen, pelvis, long bones, GI. So people do miss long bones. Which are those ones? So do that. Look at that. Then comes to the disability, assess the level of consciousness using the GCS score. Very, very important GCS score. So I would suggest you practice your GCS score on your fingertips. They can give you a GCS scores, but giving you eye opening, no eye opening, and ask you to calculate GCS score. So in exams, you don't have enough time to, look for and keep on thinking. So, memorize it on your fingertips. Then pupils assess the equality, size, asymmetry, reactivity to the light. Unequal or sluggish suggests local eye problems or the lateralizing CNS lesion. Non-reactive pupils or decreased level of consciousness, structured cause. So even we look for the people who have poisoning. So checking for the pupils. Then lateralizing motor deficits, checking which one are those ones. Because in stroke cases, we do check those ones. Then Glasgow Coma Scale, as we said, GCS is very, very important. You have to do it on fingertips. Good indicator for the severity of the injury and neurological prognosis. So you have to know, they can ask you in the MCQs, why do you check the GCS? So it is good indicator for the severity of injury and the neurological prognosis, okay? Then coming on to the sides, that fluid resuscitation, give bolus until the heart rate decreases, urine output increases, and the patient stabilizes. That's how you're going to do the fluid resuscitation. Maintenance is 4:2:1 value. So is so from 0 to 10 kg, it's basically 4 cc. Then 10 to 20 kg is basically 2 cc. So it means 4 cc plus 2 cc. Then remaining weight is basically we add 1 cc. Then replace ongoing losses and deficits. Assume 10% of the body weight. Shortcut for calculating the maintenance, they give you like more than 20 kg. Fluid rate is equals to 40 plus patient weight in kg. Glasgow Coma Scale, you have to remember it on the fingertips. If someone, like, even if you are sleeping and someone asks you some question, you can just know, oh yeah, this is this much. Unilateral and dilated non-reactive pupils, focal mass lesions, epidural hematoma, or subdural hematoma. Exposure or environment, how does the exposure is basically expose the patient completely and access the entire body for an injury. Once you make the patient stabilize, now is the last part where you're going log roll to examine the patient. DRE for the trauma patients, a lot of patients miss it, especially in the abdominal pain. Acute abdominal pain is one of the very common scenarios that come in emergency medicine, and DRE is very, very important. Keep patient warm with a blanket and radiant heaters, avoid hypothermia. Warm IV fluids, blood, and then keep providers safe, contaminated, and all the contamination you have to remove those. Resuscitation. Now, starting from how you're going to resuscitate, this part 2. Then done the concurrently with the primary survey. So we are going to check the vitals and slowly do the resuscitation. As attend to the ABCs. Manage life-threatening problems as they are identified. Vital signs every 5 to 10, 15 minutes. And then we can increase slowly the time to 30 minutes, 1 hour, depending on how the patient is getting stabilized. ECG, BP, oxygen monitors, it's something that you have to do right away. Foley's catheter, don't forget the NG tube, especially in the abdominal cases. Test and then investigations, which are those ones: CBC, electrolytes, BH1, creatinine, glucose. So you are not going to write down any case, any investigations randomly. You need to be very focused on which investigation is supposed to be done for which kind of cases and what you are looking for. Because the way they created the exam and questions, they know if you choose this answer, what you are looking for. So let's suppose if you are doing a patient who has just a trauma and you are checking a hemoglobin. So we are going to do CBC. Suppose I selected the CBC. The next person who is checking my exam or whatever it is, they will know that this patient or this person who is selecting the CBC, what they're looking for. They're looking for hemoglobin. If I checked anything else, then it means they get an idea that this person does not even know what to do. So that was very, in this case, it's not just getting a plus marks or you know anything or you don't know anything. It means that you are a dangerous person for the patient, that you don't even know what to do. So a lot of people don't even know, if you choose a wrong thing, although it's not dangerous for the patient, it means that your lack of knowledge, that is dangerous for the patient. Although checking CBC is not dangerous for anyone, but lack of knowledge is dangerous for that particular patient. Okay. So in that case, you can, a lot of people do fail the exam because of that one. Okay. So CBC, electrolytes, BUN, creatinine, then glucose, amylase, INR, PTT, beta HCG, toxicology, screen, then cross and type. Cross and type is very important to check for which kind of blood you need later on. Then contraindication of the Foley's insertion, if there is a blood at the urethral meatus, scrotal hematoma, high riding prostate, on DRE. That's why I said DR is very important. Then NG tube contraindication, significant mild phase trauma, basal skull fracture. Sometimes they don't even ask the question that you are going to do DRE. They ask, why do you want to do DRE in this case? Okay. So in that case, even in MCQs, they give you one MCQs, and in the second MCQs, they ask you this question. Let's suppose they give you a patient who has abdominal pain, and then the answer was DRE. In the next second question, like a part B of this MCQs, they ask, why do you want a DRE, or why do you choose the above investigation? Now, if you choose the DRE and now you don't know why are you doing DRE, that's also not significant enough for your knowledge, right? Then this one here, AHA, is basically checking for the step, adult, child more than 1 to 8, and infant less than 1 year. So step is basically airway, breathing, foreign body compression, how much and how are you going to do. So basically for the adults more than 8 years, you're going to do the head tilt, chin lift, jaw thrust. So we do same for everyone. for the 1 to 8 years and then less than 1 year. For the breath, 2 breaths at 1 second per breath. So stop once see the chest rise. So once you see the chest rise, you have to stop. Then the foreign body abdominal thrust, and then in the infant less than that, you do the chest compression. Then coming the compression, you can see how you're going to do for the adults, child, and then for the infants. It's kind of different. So for the adults, we do the both hands. Even for the child, we do the both hands, or sometimes we do with one hand. But in infants, we do with the fingers. Then compression and the breath, how much you are going to do is basically compression rate is basically 100 to 120. This is kind of questions they do ask in MCQs, okay? Compression ventilation ratio is basically 30 compressions to 2 ventilation. Compression only CPR, hands only CPR is preferred. If the bystander is not trained or does not feel confident in their ability to provide convention, so you can always, call the next person. Then the defibrillation is basically immediate defibrillation is a shockable rhythm, is identified compression and use AED if an unwitnessed arrest. Manual defibrillators are preferred for the children and then infants and can use adult dose AED if a manual defibrillator is not available. So just an idea about how defibrillator works. Then comes to the secondary survey. Secondary survey is basically once the primary survey is done, now go for the secondary survey. If they are looking for you to answer a secondary survey in questions, especially in the exam questions, they do tell you that we have done this, and now what you will do, okay? So you don't have to assume. First thing that's very dangerous in exam, I would suggest don't assume anything, okay? Like if it's not mentioned there, it means it's not done. Don't think that, oh, if the airway is already been checked and we are going to breathing, don't think that C cervical spine is already been, checked or it's already been corrected. Don't assume. It means now they are giving you airway. Now they're looking for, did you forget the C spine or did you already move on to the breathing? That's also one of the very thing that we've assumed, oh, if the breathing is done, maybe the airway is done. If they did not mention, it means it's not done. Okay, done. Then comes to the secondary survey done after the primary survey. Once the patient is hemodynamically and neurologically stabilized, identified major injuries or areas of concern. Full examination starting from checking from head to toe and then moving on to what kind of investigation like CT scan, C spine, chest X-ray, and pelvis required in blunt trauma. Consider T spine and L spine indicated. Okay, if indicated. Then starting with the sample, what are the history questions? Sample sign and symptoms, starting with how, what, all that, especially for the patient who, the next person who's next to the patient, if they have an idea. In the cases like seizures, they do like to ask in those things. Allergies, medications, past medical history, last meal is very important, and then events related to the injury. Okay. Now, head to neck trauma, palpations of the facial bones, checking for the chest. We are going to inspect for the midline trachea and the flyal chest, auscultate the lung fields, palpate for the subcutaneous emphysema. This line is very important, palpate for the subcutaneous emphysema. Abdomen, assess for the peritonitis, abdominal distension, and then evidence of the intra-abdominal bleeding, DRE for the GI bleed, and then high riding prostate and anal tone. Then musculoskeleton, examine all extremities for the swelling, deformity, contusions, tenderness, like you are going to check for everything, range of motion. In MCQs, they do like to ask, what are you going to check in extremities? So swelling, deformity, tenderness, range of motion, these are the things they're looking for. So the lines and the words are important. Checking for the pulses. Okay, so whenever we are mentioning, like I'm just telling you, so you have an idea what you don't miss out this one. So we write down bilateral equal pulses. Okay, so that's why the pulses are important, not just for the one limb, both of the limb, especially 4 limbs, all of the, like both of the legs and both of the hands, and sensation in all the injured limbs, checking for the neurology. Log roll and palpate the thoracic and lumbar spines, palpate the iliac crust and the pubic symphysis, assessing the pelvic stability, lateral, AP, and vertical. So pelvic pelvic injury is basically a major injury, okay? Don't take it as a light injury. So there is 2 types of injuries that will come maybe later on in traumatology. So let's do with this one. Neurology, GCS, full cranial exam, alteration for the rate, rhythm of breathing, and signs of structural and metabolic abnormalities with the progressive deterioration in the breathing indicating a failing CNS, like how the patient is deteriorating. Assess the spinal cord integrity, conscious person and unconscious person, checking on the distal sensations and the motor function in the conscious person. But in the unconscious, we are going to check for the painful, noxious, and the stimuli is applied to the extremities, like how unconscious and how much sensation is there, especially in unconscious patient. Or if there is any limb that is dying because the patient is unconscious, so we have to do full assessment. Initial imaging is basically non-contrast CT, head, face, and C-spine. Rule out all the fractures. Then chest X-ray, fast, and then we go for pelvic X-ray. Now, signs of increased intracranial pressure, important, very important. Okay, even for the neck osteoarthritis, even for interviews, sorry. Deteriorating lack of level of consciousness, deteriorating respiratory pattern, Cushing reflex, lateralizing CNS sinus signs, seizures, papilledema, and then headache, okay, nausea, vomiting, headache, these ones. Then the non-contrast head CT is the best imaging modality for the intracranial injury. Okay. Then coming to the ethical considerations, very, very important. These are not just the enough. I would suggest maybe if you can read different scenarios from UWorld as well and from the like CPA, yeah, CMPA, do it from there too. There's a lot of things that is missing from here, and then you can do it from there too. Okay, so in the ethical consideration, we will try to do those ones as well. I will try to bring out the questions and we can discuss those ones. And you can read those ones as well. So we can discuss those questions too. Emergency rule consent is not needed when a patient is at imminent risk from the serious injury. So we just start stabilizing the patient. And obtaining consent is either not possible or would increase the risk of the patient. Okay. But let's suppose if there is a person who can give the consent for that patient, and if he is the one, like a legal guardian or stuff, then in that cases, we do need to consider that person's willing what they're saying.